Okay, I think we'll get started. So afternoon, everyone. You're all very welcome to the webinar this afternoon. We hope it's going to be a good use for everyone's time. There'll be some really useful opportunities for reflection and thinking about action plans and areas for support moving forward. First off, just wanted to say thank you to everyone who's taken the time to join us this afternoon or to watch the recording once it's live and uploaded. We absolutely appreciate how much pressure everyone's under out in systems at the moment and how hard everyone's working to try and ensure that the children and young people in their patches are being as best supported as they can in what we know are really challenging times for everyone. We're, as I say, we're well aware of the pressure that everyone's under. We did think very carefully around whether to postpone the webinar or not. I think on the basis of the people who'd signed up for the webinar and what a priority area this is for all of us for many different reasons, we decided that it would be important and useful to go ahead. What's been really great to see in terms of the sign up ahead of the webinar is the representation across such a broad range of stakeholders. So we on the call today, we're expecting commissioners, providers, local authority representatives from third sector, academic health and science network are also due to be in attendance as well. So I think we've got a really broad mix of stakeholders, which will hopefully lead to some really useful and rich discussions as we go through this afternoon. So Tyra, if we can move on to the next slide, just a couple of housekeeping bits before we get started. So we are recording the webinar and it will be online afterwards. We have breakout rooms built into the day, so those bits will be clipped from the recording, but the reflection sessions that we have after the breakouts will continue to be kept in the recording, and we'll try and collate any of the feedback in written form as well to sit alongside the recording. So if you can just make sure that you're on mute and if you want your camera off, that's absolutely fine. And then if you're speaking throughout the webinar, you can come off camera and come off mute. And please do feel free to raise your hand and add points as we go along. We're also going to try to be quite active in our use of the chat bar throughout the session, so please do post any questions or comments in the chat bar and we'll try to monitor that and pick up on any key points as we go through. Okay, if we can go on to the next slide. Thanks, Tyra. One step ahead of me. So it is a live event. You will be on mute unless you're a designated speaker or asking a question. I think I've already said all of those bits. So if I just talk through our plan for this afternoon. So we're going to aim to finish by 4:30. We're going to start the session for probably about half an hour. We're just going to talk through the context for the survey itself, defining what the problem was and then what the question that arose from that was, and that was very much co-produced with system leads. To then just talk through the survey that we undertook with system leads, the themes and commonalities with other analyses that are out there. And I say we're aiming to keep that to half an hour. I'm really glad we've got Lila joining us this afternoon, who's going to co-present with me. Lila has since moved into a post in West Berkshire, but at the time was with us in the regional team and really did the vast majority of the work on this. So I think all credit needs to go to Lila really in terms of a lot of what we're talking about this afternoon. So after that first half an hour, we've then protected the remainder of the time for breakout sessions. We're going to try to allocate people to breakout rooms based on the ICS footprint that they're in. So hopefully you would have indicated that when you pre-registered. If there's any issues with that, please just let us know via the chat bar and we can reallocate you to different rooms. So we're going to have a 20-minute reflective session on some of the self-evaluation questions that have arisen out of the analysis, particularly focused on prevention. Then we'll have 10 minutes for some feedback on that. Then we're going to have a second breakout session, which is focused on some of the self-evaluation questions for systems around Postvention, so their crisis assessments and formulation and support plans following young people presenting in crisis. And then we're going to try and reserve a bit of time at the end to just think about any next steps, actions for systems, actions for us as a regional team, any support requests of each other or of us as a regional team. So hopefully it will be a useful and productive hour and a half, and a good opportunity to give you some reflective space that is probably very hard to find day to day at the moment. So Tara, if we can move on to the next slide, please. Okay, so I'm going to hand over to Lila just to set the context for the survey.
Good afternoon all. I'll try to not talk too much to the slides, so we have as much time as possible for the reflective space, which is really where we want to get to. So this really came about through some of our networking and through the different steering group meetings that we had at the time across the Southeast. A number of system leaders expressed concerns about increasing numbers of young people presenting in crisis pathways who appear to have had no previous contact with mental health or acute services. So it very much felt like young people kind of pinging out of nowhere. This was very much part of a wider picture of increased children's mental health needs that we all know about, the 60% increase in referrals. The impact of this was leading to significant pressures, not just on mental health services, but also the spin-off around acute paediatric inpatient services, and we're still struggling with that to a degree. It affected some of the bed spaces and acute paediatric beds, so the normal kind of winter crisis that we see for other conditions that children have, we're finding it difficult to find spaces within the acute setting. The typically presenting were emergency urgent cases requiring really quite significant crisis responses, either through paediatric acute inpatient care, CAMS community crisis follow-up, or ending up in tier 4 inpatient beds. The NCMD report last year found that about a third of children's suicides, sadly, were children who were not known to mental health services. And I think you'll see later on that there's some reflection around that within the findings. So on the back of that, I think there was a real feeling across the system that we need to understand better who these young people are so we can support them better in preventing the crisis, but also how we support them afterwards, crisis. So just the other sort of context that Gavin's quite keen to mention is that referral trends mirror the national picture, so peaks exceeding historic rates. Community CAMS caseloads are higher by 27% pre-COVID, and in the Southeast they are 32% higher than the England average. So that's quite significant, and that really kind of explains part of the pressure that's been on the system in the Southeast. And equally high inpatient bed occupancy than pre-COVID nationally. So it seemed quite different picture emerging within the COVID. The next couple of slides, really I'll just whisk through. So that just gives you the overview of referrals into community crisis services. And I think what you already know is that it's not a linear, it's a bit lumpy. And I think we're still sort of familiar with that within community mental health services. But in terms of a trend line, it's been an upgoing trend line for crisis services. And mental health and A&E attendance, again, very similar picture, a bit not equally distributed across the 2 years, but with some significant peaks, again, with trend lines going up overall. And then the question that we really wanted to answer with the survey was, are there any defining characteristics that will lead to an understanding of how we can have develop a preventative approach that could be tailored to identify these young people earlier and better meet their needs through early intervention so they don't end up in a crisis. So like the little boxes at the bottom says identification, early support, crisis prevention, crisis response. That was really what the whole survey set out to kind of establish. And then over to Gavin to just talk about what we already know, and then we'll go on to some of the findings.
So what we wanted to just pause to do before we go into the findings of the regional survey is just look at what we already know in terms of young people's mental health, and we know that different cohorts of young people are affected disproportionately. So we just wanted to pick out some of those themes, and then when we look at the results of the regional survey, we can think about how they might tally with any of those themes. So we know from the latest NHS digital studies of 2017, 2021 that the rates of probable mental health disorders in children and young people have increased. The figures are there. I won't read them out. I think there's quite a concerning figure that over 40% with probable disorder hadn't sought help. Within the most recent publication, the most recent report, they talked about the sources of or the avenues that young people might use to seek support if they had a probable disorder. And for under 16s, education was the most common source of help seeking. For over 16s, so for 17 to 23-year-olds in the sample, they tended to use friends and family or telephone advice to seek help for mental health problems. So it's worth us just clocking that when we come back to some of the reflective questions later on. And then we know that there are groups of young people who show high rates of probable mental health disorders. So we know, for example, that emotional difficulties increase with age. In terms of gender, we know that females are more effective, and actually in COVID period and over the period of these two time points studies, and if we go back to the 2004 data, which was the equivalent data before the most recent publications, the females have shown the greatest deterioration in terms of their mental health. In terms of health, we know that young people with special educational needs and long-term physical conditions are disproportionately affected. Socioeconomic, we know those living in low-income households or households in receipts of benefits. And this is a really important distinction here, as opposed to neighbourhood deprivation. So it's household deprivation that has the bigger impact on mental health, according to the prevalence studies from NHS Digital. And we know that family functioning is really key to worse mental health outcomes as well. So things like poor family functioning, children that are in the care system, and parental ill health, whether that be mental or physical. So if we move on to the next slide, Tyra, please. So the next slide is just an infographic from Public Health England, as it was then, that just picks out some risk factors and protective factors for young people experiencing mental health problems. But similar themes coming out, particularly in terms of the right-hand couple of columns. So there's family disharmony and breakup, there's issues around social life and socioeconomic disadvantage as well. So similar themes coming out there. What do we know about the impact of COVID on children and young people's mental health? Well, there's been a range of studies around the impact of COVID, and again, they've picked out that the impact isn't experienced equally by all children. So again, we see the older age group particularly affected, females particularly affected. There's some mixed findings around BAME, but I think there's probably some sampling issues there in some of the studies in terms of how representative they are, and young people who identify as LGBTQ plus community members. In terms of health, again, disabilities is coming through, SEN. There are some studies that suggest needs who haven't bounced back from the impact of COVID on mental health in the same way that many other groups of young people have, and those with long-term conditions, and now we have long COVID in the mix. Again, family context, very similar to what we knew before. But also adding in grief linked to bereavement and other losses, and those wider social factors such as gang violence and young people that have faced transition during this last couple of years. Okay, if we can go on to the next slide, Tyra. So you're probably already starting to see some themes. Some of these are probably unsurprising or not new to many of you, but are worth us revisiting, I think. This was a piece of work that was undertaken by our East of England colleagues, where they looked at the evidence-based brief crisis interventions, and as part of that, they looked at risk factors for admission. I won't talk through everything on the graphic, but I think on the right-hand side, again, we can see that the social box, again, there's issues around family functioning, bullying or victimization, being from BAME backgrounds, and really those family dynamics and parental child dynamics in the mix that come through in those other couple of slides that we've already shown. So we can move on to the next slide, Tara. So this is really where we're moving on to young people, not just who are more at risk of mental health difficulties, but are more at risk of crisis and suicidality. So this was from a study that was published last year, the NCMD report on completed suicides by children and young people. And again, some of the themes are very, very similar. There's themes around household functioning. There's themes around age. So if we look at the age groups, again, it's predominantly 15 to 17-year-olds. So 70% of those completed suicides were in that age group. Gender, now here there's a gender flip. So in the slides that we've seen so far around young people who are more vulnerable to mental health problems and more vulnerable to mental health crises, females have been coming through more strongly. When we look at completed suicides, actually they're more common in males. So I think, again, that needs to be in our thinking around crisis pathways, both prevention and postvention. Similar things around health, where neurodiversity, SEN, physical and mental health comes in, and family functioning, and those social experiences. And what they found was that 90% of young people with completed suicide had more than one of those factors above. The other factor that we found in our regional suicide analysis, which was completed, I think, 2 years ago now, was around faith and belief, the interface between faith and belief, which didn't come out in the NCMD study, but is worth mentioning here. Okay, Tara, if we can move on. So I'm going to hand back over to Lila, who will just talk through the methodology and headline findings from the South East survey.
Thanks. So in terms of the survey, we went back out to the systems. I produced a set of questions really outlining the learning from the information and the different surveys that we already know exist, that Gavin's just presented. It was a 3-week submission window, so in September last year, and the questions were then co-produced. And the table that you can see there are the sort of questions that were in the survey. So a bit about demographics, a bit about ACEs, a bit about sort of circumstances, and also what sort of support was delivered after the crisis, and had there been attempts to seek support before a crisis, really just to establish what the experience was in terms of the sort of pathway, and if we could tease out whether people were seeking support but not getting it, and equally were there enough support available afterwards. There were 21 returns, so not many, a bit less than we'd hoped for, but it was in a very busy period in the autumn last year, so it's not representative. And so with this is not a sort of piece of research as such, it's much more a qualitative piece of work that we want to share with you, that we want to do some thinking around, and hence the structure of today. So there was no control or comparison group with young people of similar demographic and context who did not present in the crisis. So I think the findings have to be kind of seen in that light. So in terms of findings, the cohort were 13 to 17-year-olds. There were predominant females, 15 to 5 males, and then 1 identified as a male, and predominantly white British. In fact, I think 20 out of the 21 identified as white British. Some of the information that came through highlighted some gaps in terms of, I think, probably what we would collect when somebody kind of hits that crisis point. So that were around gender, sexual identity, SEN status, health status, faith. So what we know from the suicide analysis is some of those demographics, or some of that key information around the sort of wider aspects of a young person's life, there were some quite big gaps in that data. Interesting, most of them were in education, so the only 2 were NEET and 1 was home educated, which is a little bit contrary to some of the findings that's been found in other studies. So in terms of ACEs, first time and repeat attenders, so 71% experienced ACEs, and of those 53% experienced more than one. I'm thinking that in fact it was as many as 4, so quite a high number of the cohort had significant number of ACEs. And those ACEs, the sort of consistent ACEs that came through were around bereavement. It was a bit of a mixed picture whether help had been sought previously or not, and that might just been due to how the surveys fill in. That was a bit hard to establish. but none of the first-time attenders with eating disorders or paranoia had previously sought help. So only 2 of the sample overall were open to CAMHS. Private counselling was identified in discharge plans for 4 young people, especially first-time attenders. And the sort of seeking help previously is consistent with NHS digital findings, where 41.5% with probable mental health orders had not sought help previously. Under 16s, most likely to seek help, as Gavin said earlier, through school. And I think this is quite significant in terms of how we start thinking about identification. 16 plus through friends and family predominantly, or through telephone lines. So what the NHS digital findings find is people seek help in different ways, and we need to think about that really carefully. And then over to you again, Gavin.
Okay, so this is our last slide before we go into breakout rooms. So just returning to that original question. So on the basis of the sample that we had, as Lila said, we're realistic. That isn't a representative sample. We don't have any control group. We've got no comparison of young people with similar demographics and contexts who don't present in crisis pathways. But just revisiting this question, so are there defining characteristics that would lead to an understanding of how preventative approach could be tailored to identify these young people earlier and better meet their needs through earlier intervention? So our first point, contrary to what was expected, young people had at some point been in contact with statutory services. So I think it probably is disingenuous to refer to these young people as hidden children. Now, that isn't to say that there aren't hidden children out in systems. So we're hearing a lot about young people who perhaps haven't returned to education since lockdown. So we know that there are some children who are off radar for statutory services who do need to be thought about. So it isn't ignoring that, but in this particular sample, we didn't see young people who were out of contact entirely with statutory services, but either the preventative services or initiatives hadn't reached them or hadn't prevented them going into crisis. So there's something about that linking of intelligence or concern across partners. And as Lila said, actually a significant proportion of them were in full-time education, but there wasn't any evidence to suggest that they'd been brought to the attention of mental health services by education leads, or even, to be fair, that they'd flagged any concerns with education leads to be able to have that onward referral. All of the young people had a mix of wider complex situational factors, disabilities and ACEs, which, as we went through in the previous slides, have been identified as risk factors for developing mental health problems or presenting in the mental health crisis. So again, that was largely unsurprising, but helpful to have a reminder that those themes are still there. As Lila said, there was missing data on really key areas that we know are linked to higher vulnerability of mental health problems and crisis. What's difficult to say is whether that data just wasn't there because it wasn't asked, or whether it wasn't captured in reporting systems and then subsequently in our own reports that we were receiving from systems. But I think what it does highlight is that perhaps that holistic view and needs-led approach, which we know proves important to early intervention and post-crisis support, might be lacking some components at times. Just over a third of the young people in the sample had pre-existing mental health or autism diagnosis, but it was really unclear from the returns what post-diagnostic support they'd received. And then finally, we're just noting that although many crisis pathways are experiencing increased numbers of young people with eating disorders or disordered eating, actually there was still a substantial cohort within our own sample and we know in crisis settings who are presenting with overdoses or self-harm or attempted suicide. And actually in this sample, 10% had symptoms of psychosis as well. So I think there's just something in there about us not forgetting those other types of crises that young people might be experiencing that mean that they're presenting in acute settings or crisis pathways. So Tyra, if we can move on to our next slide. So just before we go into the reflective groups, a quick reminder, I'm sure people don't need reminding of it, but around the NHS long-term plan deliverables related to crisis. So there is a deliverable for 2023 of 79% coverage of crisis provision, 24/7 crisis provision for young people, which includes all of those three components, so crisis assessment, brief response and intensive home treatment. And just in terms of funding, so there is service development funding of around about 71 million for the South East for CYP mental health community crisis and eating disorders, and around 717,000 for suicide prevention, which is targeted, that latter pot of money across the South East. But I suppose that was really just to flag that there are opportunities here where there are funding streams that can be used. And we also have the seasonal pressures and discharge funding of around 6.3 million for the South East too. So just have that in the back of your minds in breakout rooms too. So Tara, if we can move on. So our first breakout session is as I said earlier, we've tried to allocate you by ICS footprint into the breakout rooms so that you can have a conversation about your own area and crisis pathways in your own area. The first 20-minute breakout session is going to be around prevention. And these were just 5 of the questions that we felt fell out of the analysis and some of those background reports that we referred to earlier. So if I'll just go through them now. So to what extent are your approaches to early identification, monitoring and support targeted around known vulnerability factors? So those that we picked out in the earlier slides and those that came out from the analysis. To what extent are the wider CYP workforce aware of those vulnerabilities and some of those early warning signs? Do they know where to go for support once they've identified a young person in need? Do your waitlist management strategies, so this is coming more into specialist CAMS arena now, I think, do your waitlist management strategies take account of known vulnerability factors for mental health crises? And that's both contextual and demographic factors based on some of the slides that we've presented already. And then are there workforce development plans for the wider children's workforce in relation to crisis and postvention support? So we're going to give you 20 minutes for that. What we'd ask is maybe when you get into your breakout rooms, if you can allocate one person who takes some ownership over trying to keep people to time, trying to keep the discussion moving so that you get time to discuss more than one of the questions. When we come back together, we've got 10 minutes to feedback. So what we would ask is if you just have an idea of maybe 2 or 3 strengths in your ICS system in relation to prevention, maybe if there are any areas that you feel you would want to action or work on, and if there's any areas that you would just like to learn about from other parts of the region, and we're going to ask you to post that in the chat bar when you come back. So if you can come back with some thoughts prepared on those 3 questions as well. reconceptualizing it as hidden complexity, which looks like a point that's been echoed a few times throughout the chat bar. And again, picking up on this cross-agency working, particularly with local authority partners as well, and that's certainly something that we're trying to support and facilitate as a regional team. So we've got calls with system leads currently. I know we've had one with I think West Sussex and one with Kent and Medway already, but there should be some in the diary just to think about partnership in crisis pathways, and again, probably definitions become really important there as well, about being clear on what's being defined as crisis and what's being defined as complexity or hidden. Okay, I'm gonna as I say, we'll try to collate what's in the chat bar, because there's such a richness there. Are there any key areas before we move on to the next breakout session that any of the systems were thinking, we'd really like to learn from other systems within the Southeast, what they're doing on this particular issue? Lila.
I think there's one important point that Guy raised in the Bob group that hasn't quite been reflected here, and that is children who are not in education, who are being homeschooled. So our survey didn't really bring that out as an issue, but they've done a piece of work across East Berkshire, which illustrates that it is a significant work, and quite vulnerable children who are being homeschooled. So in terms of a matrix, we were sort of discussing, can you develop some sort of risk matrix? And that is a complex thing to do, probably, that everybody would use. But I think Guy sort of said, well, actually, that is one place that you could really start. You could start thinking about that cohort as a really significant risk area.
Thanks, Lila. Yeah, and really important not to forget that cohort, although they didn't come out in the survey that we did. We know that there is that group of young people who aren't in education or haven't returned to education. Guy, did you want to add a comment there?
Yeah, it was just the cohort. What we were looking at didn't specifically identify that cohort, but it's just another way of looking at complex cohorts is through the GP data and the population health data. So we don't just use the data through schools and education. And it may even be that education is recorded better in GP data than it is elsewhere. I don't know, Katie's there, but I'm always quite impressed with GP data, to be honest, whenever I get a chance to look at it.
Yeah, I wouldn't necessarily think it would be better than education data, but certainly for identifying children who've been through the care system, or potentially children who've been on a child protection plan. Our coding is usually pretty good because we're the ones that do the reports. So I think that vulnerable cohort would be identified probably more easily through a GP system. Yeah.
Thanks. Yeah, and really good thinking about how we use data and risk matrices as well here to identify young people. I know Brighton and Hove in particular, I think local authorities have had to look quite carefully at electively home educated children, but also those not returning to educate. I think there was a family that took the local authority to court over whether they were able to get in to see the young people and make sure they're fulfilling their safeguarding duties. So certainly something to be having conversations with your local authorities about too. We'll take one more question and then we're going to move on to the second breakout room, just so we've got enough time. So Kate.
Hi, we're talking about hidden children, and I was the one that mentioned about redefining hidden children, but actually with this mention of homeschooling, I've suddenly reflected the other group of truly hidden children, as well as the homeschooled, are the refugees and asylum seekers. And obviously, Berkshire West, I don't know about others, but we're seeing a growing number of those young people who are presenting to us on arrival to the UK with some serious safeguarding and mental health complexity that is very difficult to deal with. So I wonder in a few years' time whether some of those very, very young children who are not yet known to services are going to start emerging as well.
Yeah, Kate, thank you. And so going back to the point really about us defining what we mean by hidden children or hidden complexities, and there may be subgroups of young people within that all need to be thought about so that no groups are missed. Olivia, do you want to come in? I'll give you privilege to come in before we go into the second breakout room.
Oh, sorry. Thank you. I was just going to add to even the point that's just been made. There are even further subgroups within that, and we're very lucky to have Vicky Gray as our head of safeguarding regionally, because she's been leading on some work at national level. So within the UASC, there's now, so the unaccompanied asylum seeking children, there's a national transfer scheme, which means that each region in turn will receive a contingent of children to accommodate with the 20 days for all statutory health and care assessments to be undertaken. And then within the Afghan refugees, I think the discussions at the moment are whether children are within families or they came as refugees with whoever, neighbours, aunties, uncles, and that will probably create some hidden trauma and needs at some point in time.
Okay, so look, thanks for everyone's contribution in the chat bar and verbally feeding back on that first reflective session. I'm really conscious that today might raise some questions and actions back for systems rather than necessarily resolving anything on the day, but hopefully that will be as useful in itself. So our second session, we'll try to keep it probably to 20 minutes, maybe 15 to 20 minutes, just keeping an eye on time. So this next session really is looking at postvention self-evaluation, so slightly longer questions, but again coming out of that analysis that we talked through earlier. So on assessments, explicitly ask questions relating to vulnerabilities, known vulnerabilities. So as Lila was picking out earlier, there were a lot of gaps in information. It's very hard to know whether that was because it wasn't asked as part of crisis assessment or wasn't recorded, or a combination of both. So that's the first question. Second question: do discharge plans, crisis management plans and subsequent support available for young people take account of the above and show consistency with a trauma-informed approach, particularly thinking about that prevalence of ACEs? Third was, given the above, are crisis pathways co-designed or integrated with other statutory and VCSE partners to ensure that holistic approach? Fourth point, are brief evidence-based crisis interventions included in crisis provision? I can say a bit more about that when we come back to. And then finally, just recognising, or as we have done already, different definitions can vary. So what definitions are used in your crisis pathways, and then those shared definitions across families and young people and local authority VCSE partners. So we'll give you, I think we'll have to cut this to 15 minutes. So we'll put you back into the same breakout rooms and then we'll come back together just after 20 past.
So I think the sort of key thing that came through really, there was some really good thinking that happened. There was agreement that there had to be a shared formulation and understanding of roles and responsibilities and shared language. And there was an example of one Reading partnership. People felt did this really well. It was multi-agency, very senior people turning up in a regular time, discussing children. They had shared vision and had money to actually go in and support children and young people. What else was there? So there's another thing that was brought up was what we need from the regional team is around national leadership. So I think what was sort of the elephant in the room was that there's a lot of funding coming through the NHS, but you've also got 50% reduction of funding in local authority budgets for preventative services. And what we need really is joined up strategies that don't drive us apart. What else was there? So yeah, single budgets to transcend existing barriers, the importance of co-design crisis pathways with all stakeholders from the beginning. So I hope that sort of my group sums up what we discussed.
No, that's really useful, thank you. And anyone from any of the other breakout rooms want to just share next steps either for their ICSs or next steps in terms of support requests?
just quickly. Sorry, it's me again. We are doing a piece. That's all right. We're doing a piece of work at the moment with Portsmouth Hospital Trust, because there have been a number of children. This is at the kind of the very kind of extreme end, that have been in the paediatric ward, where actually they are medically fit for discharge, but there isn't anywhere for them to be discharged to. Not quite the same scale as issues around adults at the moment, but somewhere between the local authorities and the mental health providers, we're not quite getting that right. It's a tiny number of children, but they're still inappropriate placements, and we've got to get those pathways working a bit more effectively.
Yeah. Thanks. Any other groups? Kate.
Hi, Sarah. I just wanted to carry on that conversation about the stranded and super stranded waiting, medically optimised for discharge, but with nowhere to go. The number is quite small, but that number is growing massively in paediatrics, and obviously we are a single ward patch in most hospitals. So whilst the number is low, the impact on operational flow through the ward is absolutely enormous.
Yeah.
So, as I say, we'll try to capture all of the comments in the chat bar. If you have other things that you would want to add, other reflections, other asks of each other or of us as a regional team, then please do make sure you put them in the chat bar. Hopefully it I think it probably closes at the end of the webinar, so there won't be a chance to add things after the webinar. So just a couple of updates in terms of direction of travel currently as a regional team, but obviously we're keen to co-produce this to make sure it's of most use to all of you. So as I mentioned earlier, East of England have done a piece of work around it's a rapid systematic review of evidence-based brief crisis interventions. We're linking in with them, they're revisiting the literature that they looked at to see whether it speaks to young people who have multiple needs, so cross-cutting social care and health needs, and or neurodiversity and learning disabilities. So they are updating that over the next couple of weeks, and they are putting together an implementation matrix to serve as a decision-making guide for systems or services in terms of their own crisis pathways and which interventions might fit best for their pathways. So we're working quite closely with them on that. That should be available in the next 4 to 6 weeks. So we'll be sure to share that once that's there. And if it would be useful to have any support around using that matrix or implementing any changes in your crisis pathways, then do let us know. The other thing at a more strategic level, as I said, we're having meetings with each system with ICS health leads, provider leads and local authority leads, just to look at how some of the challenges in timely discharge of young people who are medically fit for discharge, but also looking at identifying and supporting those young people upstream, which includes the health offer to young people in social care placements or on the verge of social care placement. So again, hopefully that will be completed in the same time frame, the next 4 to 6 weeks, and we plan to share some themes from that and then look at any actions coming out of that in terms of bespoke support to individual systems around that. There's a slightly longer term piece of work which is around market stimulation around social care placements and identifying what some of the challenges are to social care placements, taking on some of these young people with multiple needs, more complex needs, and looking at an in-region procurement process to expand the number of placements available in region for those young people with the highest level of multiple needs and complexity that currently either going out of area or sat in beds or going through multiple social care placements. So again, we'll keep everyone updated on that. We're just going to end, if it's okay. I appreciate everyone's time, and we're at 4:30. We'd just be really useful if people could take a few minutes to complete Menti, just to give some feedback on today. As I say, we're conscious that we've been tight for time, but it's hopefully stimulated some useful reflection and ideas or actions to take back into your systems or as Janet said, places. So there's a QR code in the chat bar, otherwise you can go to the Menti website on the slide and there's the code there to use. Okay. Tyra, Lily, is that our last question on Menti?
Just got one last one. Any themes for future webinars on this topic? And that's it.
I appreciate we've lost quite a few people from the call now. I noticed one of the bits of feedback on the previous slide was around having the right people in the room, and that's absolutely something that we're trying to achieve with the system leads calls with each of the individual systems over the coming weeks, and then thinking about actually how are those local partnerships working, and is there anything that can be done to strengthen that partnership working across local authority, third sector and health. Excellent. Okay. So thank you to those of you that are still on the call. We'll finish there and let you all go off about your business for the rest of the day.
Thank you. Thanks everyone. Bye bye.
Thanks a lot.
Everyone. Bye bye.
Thanks.